Very good evening to all of you. I, Dr. Vipul Maheshwari, and I'm going to present you intervention pulmonology in critical care, recent advance. So, as we all know, that indication for common indication for bronchoscopy in critical care are mostly related to diagnostic and therapeutic value. Most common indication in critical care is ventilator-associated pneumonia, severe community-acquired pneumonia, acute interstitial lung disease, and intrathoracic tumor, benign or malignant. And in therapeutic point of view, that atelectasis is due to mucus plug, benign or malignant central airway obstruction, inhaled foreign bodies, and massive hemoptysis. So further moving in that, we had one article which is recently published in British Medical Journal that efficacy of different respiratory supports to prevent hypoxia during plexical bronchoscopy in patients with chronic obstructive pulmonary disease. So basically, it is a triple-arm randomized controlled trial. So you can see that on screen that at one side, high flow nasal oxygen support through which bronchoscopy has been performed, and at other arm there is non-invasive ventilation mask. So in this study, they divided patients into total 90 patients divided into 30, 30, 30. That is 30 patients in control oxygen common oxygen therapy, high flow oxygen therapy, and non-invasive arm. So based on that age, sex, smoking history, pulmonary function test, they divided those patients, and most of the patients are of the similar characters. So here we can see that in this study, most common complaint of nose pain, which was observed with a patient who undergone bronchoscopy with support of non-invasive ventilation. And similarly, after this, also patients had complained of like whether what was their experience with this with support of invasive ventilation or high flow oxygen therapy. So most common complaint here we can see that requirement that baseline oxygen was there PaO2, which is around 69, 68, and after procedure 84.27 with the non-invasive ventilation, and the requirement of conscious sedation with midazolam and fentanyl was higher with this high flow nasal oxygen, but they could not found it statistically significant. Here, so the result showed that COPD cases undergoing bronchoscopy found that NIV is associated with significantly lower episode of hypoxia, but NIV was associated with lower operator ease of doing procedure, because through that mask it is difficult to maneuver the scope, and also the higher failure rates in NIV arm could have been fact that technical challenges insert the bronchoscope from channel of the face mask. Finding also supports the use of high flow oxygen therapy over NIV in COPD cases due to better procedure yield with high flow oxygen therapy. None of the patient had clinically significant elevation in level of PaCO2, which is theoretically in COPD patient that high oxygen concentration may be related to rise in PaCO2. Even though dose of sedative agents used are higher in the high flow oxygen therapy, but comfort levels did not differ among the three arms. Higher incidence of nose pain reported in the NIV group could have been due to need of manipulation of the scope to reach up to the nostril. So limitation of this study was that it is in single center experience, and the practice at other centers may be vary, and sample size was also 90, and they use in-house modified NIV mask to perform this procedure and maintain the ASL. The number of comorbidity reports in study are less for a cohort of COPD subjects. In conclusion, NIV and high flow oxygen therapy found better for superior to conventional oxygen therapy for oxygen supplementation during bronchoscopy procedure. NIV is associated with poor operator ease of doing procedure. High flow oxygen therapy may be recommended in prevent hypoxia without compromising on the patient's comfort or the operator's ease. So still multifactorial randomized control trial can be helpful to further generalize this thing.
Thank you. Yeah, thank you, Vipul. So I think it's a major study. Why? Because it's the first study coming up from India also, and the first RCT to compare the three different interfaces. And HFNC, since its introduction, its indication have been ever expanding. But I would like to know from the panelists, both of you work a lot in critical care also, that what are the challenges that you face when you have to go and do bronchoscopy, not just in COPD, but any acute hypoxemic respiratory failure patients? And maybe with or without NIV. So I will begin with Dr. Manoj sir first, if you can take up the question.
Thank you, Dr. Richa, and good presentation. Study has a lot of limitations. As a matter of fact, if you see the cohort, none of these patients had hypercapnic respiratory failure, although this was a cohort of COPD patients, but CO2 levels were not high in these patients. So that's why this cannot be replicated in all the patients COPD, where generally we have patients with hypercapnic respiratory failure. Now, coming to your question, what problems do we have? The problem is the patients are already quite tachypnic, dyspneic. I'm talking particularly about the hypoxic respiratory failure. And as a bronchoscopist, you always fear if you put a scope inside, the patient may deteriorate. Now, the patient can deteriorate because of the disease progression itself. Patient can deteriorate after bronchoscopy itself. But then the blame would come that it is the bronchoscopy which has caused the clinical deterioration in this patient. So leaving that point apart, in a hypoxic patient who is in high flow oxygen, say requiring 60-70% of FiO2 or NIV, high NIV, it is really challenging and difficult. And really you have to be very careful. And when it's really you do a procedure only when it is justified, it's likely to change the management of these patients. Otherwise, it is not a preferred idea to do a bronchoscopy in such critical ill patients. So that is one. So one is the mindset of the bronchoscopy. Secondly, the criticality of the patient. And thirdly, of course, various complications which can occur with bronchoscopy would be higher in these kinds of patients. Of course, you take all due precautions. Generally, these scopies are done in ICU care. And the kind of infrastructure that we have, we are able to manage most of the complications. And suppose something happens, you can just withdraw the scope and, take care of the patients. But still, the complication rate like bleeding, pneumothorax, all those complications are likely to be higher if you do a patient, to do bronchoscopy in these critical ill patients. Now, coming to, my choice and what choice is. So I would see on which support the patient is comfortable. Is patients comfortable with CO2, the oxygen therapy, or comfortable with HFNC and is comfortable on and stable, relatively stable on NIV? I would not like to change it. I would see if he's comfortable in NIV, I would do bronchoscopy NIV only. Why would I change to HFNC in that patient? Or somebody who's doing reasonably well in HFNC, I would do with that. So that would be my preference. Right. Second thing is, if the patient of COPD is there, has got hypercapnic respiratory failure, it's not a very good idea to do a bronchoscopy in HFNC. These patients, majority of these patients would be on BiPAP, would be on non-invasive ventilation, and you would do, bronchoscopy with NIV rather than switching them to, only oxygen therapy. Now, coming to the masks, now the various masks are available. You got the ports where you can put the scope through the nasal route, through the oral route without much of a problem. And it's not very difficult. In the study that Dr. Dhruv has done, he has customized a mask, which may not be very, maybe sort of a jugaad idea, which cannot be, compared in this kind of a, comparative study as superior or inferior. So I think I would go with the patient's requirement. If his patient is comfortable with NIV, I would do with NIV only. If he's on HFNC, I'll do with HFNC. And oxygen therapy, I would do with HFNC. I don't want to change just before the scopy, to any other modality. So that would be my idea. So that's it. Dr. Richa, to unmute yourself.
So maybe, so what you're trying to say that you don't tend to disagree with the paper, but yes, you will try to see the condition, the indication, the criticality of the patient, and then you will decide whether to choose NIV or HFNC. a very valid point that you made, that none of their patients, although they mentioned it's moderate to severe COPD, none of their patients were in chronic hypercapnic respiratory failure. If we see the baseline ABGs and CO2 values, so that is surprising one. And also, I would have liked to see if they could have done transcutaneous capnography also during the procedure, whether how much the CO2 is rising with the HFNC. And yes, as you pointed out, that you are still comfortable. So for you, it's not much of an operator difficulty while you are doing NIV. And there are many indigenous companies also who come up with NIV with valve so that you can just do the bronchoscopy easily. So you're still okay with using NIV if you have to, really have to.
See, if the patient got ARDS, who's got a congestive heart failure, possibly who doesn't have a problem of COPD, where there's a pure hypoxic respiratory failure and is doing well on HFNC, I would not switch this patient to NIV.
Okay.
Patient, I don't think there is a problem with doing, bronchoscopy with HFNC. But a COPD patient with hypercapnic respiratory failure, he's on majority of time is on NIV. In fact, 100% he is on NIV, not on HFNC. Their oxygen is not a problem. COPD problem is basically hypercapnia. It is not oxygen.
Yeah.
Give one their oxygenation is maintained. The problem with the hypocapnic, the hypoxic respiratory failure, the ARDS patient would require high oxygen requirement. And these are the patients who are likely to become more unstable, going more into the hemodynamic instability and more complications of bleeding and pneumothorax. Whereas in COPD patients, the problem is of hypoventilation more. So during bronchoscopy, possibly their CO2 levels may go up, their hypercapnia may worsen. And if you give some sort of sedation, those patients, they can still go on vent. So I think that we have to really find out what is the subset of the patients. If there is hypoxic respiratory, HFNC is good enough, but if it's a hypercapnic respiratory, it's better to do with the NIV support.
Okay. So I would now like to move on to Dr. Bindru. What is your take on it? And do you also face difficulty while doing NIV, or you are with Dr. Manoj that, it depends on the indication and maybe in certain cases you will prefer NIV and you don't really face that difficulty while doing the bronchoscopy?
Yeah, well, I'll say that you have got the masks now, wherein you can insert the scope through the mouth, into the mouthpiece. So definitely, if you are trying to insert the mask, the scope through the nostril with a BiPAP mask, it will be difficult. And that was the only thing which they could find out was inferior to HFNO. But what Dr. Manoj rightly said, that COPD patients, I'll be more comfortable using an NIV rather than, in particularly in ICU settings, where you do know the patients are so unstable, there are chances of hypoxia, there are chances of hypercapnia, hypoventilation. They'll always have an increased dead space in ICU settings. So I'll be more comfortable using an NIV rather than an HFNO in these patients. But with a better mask fit, wherein I can directly go through the mouth rather than trying to, make my way through the nostrils. Yeah.
So we all agree that continuous oxygen therapy definitely is our lower preference than the NIV and HFNC. And maybe when the patient we are suspecting will go into hypercapnic respiratory failure, we will prefer NIV over HFNC. And it all depends on who's doing and how much experience, and maybe that much difficulty during the maneuver is not really a concern while you're going for it.
So, Dr. Richa, we should consider that all patients with moderate to severe COPD have got a tendency to go into acute or acute on chronic type 2 respiratory failure. What you rightly said is that it was very surprising why none of these patients had, even when they were moderate or severe COPD, they never had any CO2 retention evidence of any type 2 failure. Transcutaneous capnometry, yes, they have said that this was one of the limitations of the study because that was not available. But yes, if there is there is a chance to do a multi-center study on this subject, a transcutaneous capnometry is a must for these patients, so that you'll be able to find out whether there is any CO2 retention. And with HFNO, because HFNO is obviously it gives some sort of PEEP and expiratory PEEP, compared to oxygen therapy, but it is always inferior to NIV for the need for avoiding the chances of patient going into type 2 respiratory failure. But yes, so a transcutaneous capnometry would be a better idea whenever some centers are planning to do a study like this.
So my question about transcutaneous CO2 is, there is a time lag of the CO2
Yeah.
reading that you get. So it's about 15 minutes
Yeah,
time lag. So it's not giving you real-time CO2, elevation in these patients. By the time you get to know the transcript CO2 level, you're finished with the bronchoscopy procedure most of the time. You're not doing very, it's called interventions in these patients majority of time, like you're doing any biopsies. Most of the time, these are simple biopsy. We are taking lavages and coming out and removing the secretions. So I think TCCO2, because of its time lag, may not be very appropriate, as a matter of fact. That's my personal opinion.
Okay. And they did do ABG 2 hours post the procedure where they didn't see any CO2 retention. But I think then to begin with, they had lower CO2 levels in their patients. And also they selected more of stable, although it was RCT, but they selected more of stable COPD patients rather
yeah.
than patients who were in critical settings.
Mm-hmm.
So probably that could have been the reason. Although low BMI, they were quite low BMI patients. I would have expected some few to be at least chronic hypercapnia
Chronic
respiratory
hypercapnic,
failure.
yeah.
Yes, that was one thing. But besides COPD, sir, any other indication you would like to extend HFNC, like while doing bronchoscopy? Yes, maybe another acute hypoxemic respiratory failure. Any other conditions where you would like to use HFNC? Not over NIV, but maybe while doing the bronchoscopy, just as a prophylaxis to prevent hypoxia.
So, non-hypercapnic conditions like Dr. Manoj Goyal said, ARDS or a cardiogenic pulmonary edema, where it has been now shown as akin to CPAP, HFNO. So, I think those are the conditions. If you need to do a BL in them, or any sort of minor procedure, minor intervention in them. So these are the conditions where I'll be patients with pneumonia also without COPD. Now, where you can who need high flow oxygen, there I think as we all know that NIV is not a great source of support in type 1 respiratory failures. HFNO is a better one in them. So these are the conditions where HFNO can be a better option for doing the bronchoscopy in ICU patients.
And maybe OSA, sir, Manoj, sir, what do you think that patients who are on high risk and high suspicion of OSA patients, maybe not OHS, but who have OSA?
You would use NIV rather than HFNC. So because you giving high EPAP, you can open up that the upper airway. So OSA patient, OHS patient, NIV would be preferred.
Yeah.
Okay. So we'll move on to the next study, Vipul. You can begin. I think we are running late.
Yes, ma'am. So next study related to cryotherapy. So one of the common indications for cryotherapy nowadays is malignant and benign central airway obstruction, low-grade airway malignancy, foreign body removal, and endobronchial biopsy and transbronchial biopsy. So this study is cryotherapy for the treatment of tracheal stenosis, which is commonly related to post-intubation tracheal stenosis. Now present in a systemic review recently published in Curious. So it was again, it is a retrospective study where they included 5 different studies and analyzed them. So most of the studies that Fernando, Leo, Jung, Kisme, and Bora, where they included most common location of this tracheal stenosis subglottic, followed by stricture and thyroid stomach tracheal stenosis. And treatment modality they use in Fernando is pre-cryotherapy, followed by balloon dilatation. In Leo, they use cryotherapy alone. In Jung, also, they took one patient with cryotherapy. And in Bora, they use spray cryotherapy. So results of this study was that total of 67 patients were included, and with tracheal stenosis and subglottic stricture were the most common sites of stenosis. 29 patients were treated with cryotherapy alone, while the rest 38 patients with cryotherapy followed by balloon dilatation. After the intervention, 48 patients experienced improvement, 5 experienced no change, and there is 13 patients were asymptomatic before the treatment. No complications were reported in 65 patients, with only minor complications reported in the rest with the cryotherapy. So again, discussion part that Vittel reported that tracheal intubation lasting longer than 6 days increases the risk of stenosis to 5% from 2% for intubation lasting between 3 to 6 days. Another study with Dungan et al. Revealed that intubation is a little 18 hours can lead to development of tracheal stenosis. It takes 4 to 6 weeks to develop post-intubation tracheal stenosis. A study conducted by Shin et al. Total of 117 patients with post-intubation tracheal stenosis showed the mean time for tracheal trauma for diagnosis of post-intubation tracheal stenosis was 1.8 months. The standard treatment for complex tracheal stenosis is tracheal resection of the stenosed part with end-to-end anastomosis. Multiple different options nowadays available for treatment of tracheal stenosis, including endoscopic procedure, laser ablation, and electrocautery, argon laser coagulation, application of mitomycin C topically. Mechanical approach include rigid bronchoscopy, balloon dilatation, cold therapies, including cryo-debridement, and cryospray, and airway stenting. The recurrence rate with bronchoscopic dilatation can be as high as 90% in complex tracheal stenosis. Therefore, bronchoscopic balloon or mechanical dilatation should only be considered to bridge the treatment. Cryotherapy is a new approach that helps to accelerate the healing response, resulting in less fibrosis, and the integrity of the extracellular matrix remains largely intact. An intact stroma provides the structural support for the appropriate wound healing, resulting in decrease in the need of duration of the time of intervention. In Rogers et al. Reported that first successful use of endotracheal cryotherapy for the treatment of tracheal stenosis in 1977. Follow-up study by them, it was proved that cryotherapy is successful curing airway stricture in 20 out of 24 lesions. Airway stenting complication like including migration, obstruction, granuloma formation, relapse after stent removal can be prevented with the use of cryotherapy. Compared to other treatment modality, cryotherapy is significantly cost effective and is relatively simple procedure. Limitation of with studies, it is a major limitation that inclusion of only retrospective studies. Small size of population also, most of the studies did not mention associated comorbidities of the patient. There was lack of uniform guideline for the use of cryotherapy. Most of the studies did not mention the patient's follow-up after the treatment. Conclusion, poor surgical candidate bronchoscopic cryotherapy can be considered as an alternative as it is easily performed with fewer side effects and excellent outcome. Further studies and prospective trials are needed to validate the efficacy of cryotherapy for the patient with post-intubation tracheal stenosis.
Thank you, Vipul. So if we can conclude, they did show that cryotherapy was a good and excellent modality for treating post-intubation tracheal stenosis, but then the study had many limitations, as you highlighted. So Manoj, I'll start with you. That among all the local bronchoscopic therapies, whether it is ablative, dilatation, or stenting, how do you choose and what do you use most commonly? And your experience with cryotherapy?
Okay, so Dr. Richa, cryotherapy has been available for ages, right? It's not a new modality. And basically, we as a bronchoscopy used to use cryotherapy only for interventions, not cryobiopsy. It is a recent, introduction of being cryobiopsy or transbronchial lung cryobiopsy is a recent one. So now coming to a question, this has never been popular because the modality is slow acting. And if you look into the malignant lesion, if the growth is there, which is not causing too much of respiratory distress to the patient, not too many complications are there, then possibly you can use that modality there, because majority of the time you would use a freeze and thaw modality, where you freeze it and then thaw it, and then the tissue ablates over a period of time and the slough is cupped out. So it has not been very popular. The first study, which I'm listening to this study for the first time, where it has been used, a benign stenosis. Now, benign, as far as is concerned, there can be two. There is a circumferential, and then there is a complex. Circumferential, where the cartilage is not damaged, where there is a area is less than 1 centimeter. Possibly in those cases one can use it, but I think thaw and freeze and thaw method may not be very fruitful in these patients. What you would do, you would do a resection sort of, where you would freeze it, then pluck out the entire tissue. That would be the way it will be. I don't think it will be very useful in patients who have got a complex stenosis, significant fibrosis structure, where it's not going to be effective because it's not going to do anything there. And coming to a question, what I prefer, see, it depends upon what my experience is, what modalities I have available with me. So I can have, rigid bronchoscope with me. I can have cryo. I can have, APC, the laser, the electrocautery, balloon, and everything. Most of the time, you'll end up using everything. Okay, so it becomes a multimodality approach.
Multiple.
Not that you're fixed with electrocauteries. For example, there's a circumferential stenosis there. You would do a, electrocautery incision there, make a Mercedes-Benz incision there, put a balloon there, dilate and put a stent. So most majority of the time it becomes a multimodality approach. But I think cryo resection or cryoablation would be quite lower down, especially benign stenosis. In malignant stenosis, yes, where the tissue is soft, friable, there it may be useful, but where benign stenosis, there where the tissue is rigid, tough, it may not be very effective. And having said that, by treating with any stricture in the trachea or the airways where it is benign or malignant, the first it should go to the ENT surgeons or the thoracic surgeon. Once they say no, it is not resectable, it is beyond their approach, then the role of the interventional pulmonologist comes. And secondly, the size of the stenosis should be less than 4 centimeters. That is also important. And third thing is what are you going to achieve? Do you have got a compliant tissue distal to the stenotic area? That may not be applicable in tracheal stenosis, but yes, in a lobar stenosis or the bronchial stenosis, where somebody has got a collapse there for about years or 2 years or 3 years, even if you open up the stenotic area, it may not work because the area becomes fibrotic and bronchiectatic. So that's my point. The majority of time, I would use a multimodality approach, and cryo would come very lower down in my approach.
Okay. So I agree with you, sir. So maybe your approach is to involve the surgeon right in the beginning, and especially in complex tracheal stenosis, and once they say okay that you can go ahead and maybe then you intervene, but you involve the surgeon right from the beginning, and also how about spray cryotherapy, because that is something that we can use, and that is I think interventional pulmonology has evolved a lot from gastro. We have learned a lot from gastro, and maybe we are a decade behind them, but they use a lot this spray cryotherapy and then dilatation. And if I was just going and reviewing the literature, and they have said that when cryotherapy is used, then there are less number of procedures. Frequent procedures are quite less, whereas when you do balloon dilatations, we use cautery, APCs, the number of procedures are more. Maybe that is more promising to me. That is the only thing that
So esophageal strictures do not have the cartilages, right? And they're not very tough. They're not extremely fibrous. They're relatively soft tissues. The idea of cryo would be to cause lesser of fibrosis later on, because if you do a balloon dilatation or maybe use some sort of a laser or electrocautery, then it can lead to a lot of post-procedure fibrosis, where the chance of recurrence of the stenotic area becomes high, and as the study showed, could be as high as 90%. Possibly that recurrence rate would be lesser with cryo, but we should not compare the esophagus with the trachea or the bronchial. They're totally different.
Okay.
So what my take on this? Yeah.
And how do you decide between flexible and rigid? Like, how do you decide that what I'm going to go with, or you always keep rigid as a backup?
So it again depends. So I've got a stenosis which is not too long, which is not too old possibly, where which seems to be quite compliant, then I would possibly go ahead with rigid straight away and try to dilate the stenosis with using rigid, causing a sort of a serial dilatation. Serial would always be the first preference in majority of the cases. If you're doing pulmonary intervention, because it makes the procedure faster, quicker, right? And you have got a safer airway to manage. But if you don't have a rigid bronchoscopy, that does not deter you for doing these pulmonary intervention with flexible bronchoscopy. Preference should be rigid. But if you don't have rigid, then you can do flexible. But then majority of the time you would intubate this patient, or you would either use LMA. Then do it, because you have to go in and out repeatedly. And then your procedure is going to take a lot of time. It can take much longer time as compared to the forceps that you use for rigid. You can pluck the tissue out completely in a few minutes, where with flexible it may take a long time. And newer modalities like macrodebride, I don't know whether ENT people are quite familiar with this. They've got a tumor there which is causing almost complete obstruction of the airway, right? You can do this debridement. The mechanical debrider is there, which is there with the ENT people. Now we've got an extended debrider with us as a pulmonologist, and you can just debride it. It's a rotator knife, which debride and suck it out. It does the procedure very, very quickly. It could and it would do remove and suck out all the tissue. When it's cutting through the tissue, is also sucking the tissue out. So that is again something there which you can do only with rigid bronchoscope. So we would prefer a rigid scope for doing any intervention. But I don't have a rigid, then I can still go ahead with flexible scope, possibly with similar result. But yes, it will be more time consuming, and we need possibly a patient on LMA, and maybe intubated. Yeah.
Okay, so in the interest of time, we'll move to the next study. Vipul.
Yes, ma'am. So our next study will be satisfaction and tolerability using virtual reality as an adjunctive treatment during flexible bronchoscopy. It is a randomized controlled trial which is recently published, and you can see that in the image that patient during the bronchoscopy along with using of virtual reality video and audio visuals. So again, this study is divided into two arms with the intervention group 40 people and in control group 40 people. So 40 people undergone with bronchoscopy with the along with the VAR and VR, and 40 people without VR. So what was their uh, experience during the bronchoscopy with the help with the aid of VR, and what is the experience without VR? In this study, they that 80 participants enrolled 40 in each arm, which breathlessness, cough, and anxiety post bronchoscopy were significantly less severe in the interventional group comparatively control group, and pain was not significantly different in the both arms. So here you can see that breathlessness and cough was quite low during in intervention group, whereas there is very minimal difference between pain score. So this study evaluated the effectiveness of VR as an adjunctive treatment in fiber optic bronchoscopy, which serve as a distraction to the participant to increase the tolerability of the fiber optic bronchoscopy. Even though participants in the intervention arm did not show a significant lower pain sensation than the control group, analysis showed a lower median pain score reported by the intervention group. In a Dete et al. Published that the distraction therapy with the sights and sounds of the nature significantly reduced pain during the fiber optic bronchoscopy. Dubois et al. Also reported that the patient undergoing fiber optic bronchoscopy while listening to music were more comfortable and complained of less cough compared to the control group. Patient given appropriate audiovisual input as a method of distraction reported less anxiety and pain. As a result, look deeper breaths and complained of less dyspnea than control patient. In midazolam and fentanyl was sedation used in participants undergoing flexible bronchoscopy. There were no significant difference between sedation used in control group as compared to the interventional group. And sedation use did not play a significant role in reducing the pain, breathlessness, and cough in this study. Claiming et al. Reported that audiovisual distraction increase satisfaction by reducing cough, pain, and dyspnea associated with fiber optic bronchoscopy and improve patient tolerance towards the procedure. This also increased the likelihood of the return for the repeat procedure if required. In Angela et al. Reported that VR has consistently been demonstrated to decrease pain, anxiety, unpleasantness, time spent thinking about pain, and perceived time spent in a medical procedure. So limitation of this study was that it is a single center study. Participants were limited to single bronchoscopist. A further multi-center study would help. And another limitation, it is the possibility of recall bias of participants regarding answering post fiber optic bronchoscopy questionnaire. VR in fiber optic bronchoscopy led to better satisfaction and tolerability compared to fiber optic bronchoscopy without VR. Also significantly lower the anxiety scores in the VR.
Thank you, Vipul. So this study interests me a lot because virtual reality, definitely distraction therapy is something that has been there for long, and not just in, I think, bronchoscopy, but many other fields also, especially in burn patients. And but virtual reality is more immersive and more comprehensive, definitely. And I know personally, my colleague, my batchmate actually used last year in January, and the patient's ease and comfort was way more. and the anxiety levels are way less for him. But then this was just 2 patients that he did in. So I'll start with Dr. Bindu, sir. How likely, if available, how likely are you to use in your patients? And would you like to use in all or maybe in a subgroup of patients?
So virtual reality is is a good modality, because even if you see sometimes in our bronchoscopy suites, uh, we had tend to use music, not for the patient but for ourselves also. And it also showed that when we are doing it, or sometimes if you are humming some music and doing a procedure, it definitely leads to less anxiety in you also, leave aside the patient. So I think it's a win-win situation for both. But in this, they are focused more on the patients. I personally feel that distraction therapy should be used in patients, particularly patients who are more anxious, who are type A personality, whom you see that at the start of procedure, they tend to, who are asking you more questions at the start of the procedure, or when they are coming to you in the ORs or in the OPDs. And patients, the moment you start prepping them for the procedure, and they start having the tachycardias or increased breathlessness and all those. Those are the type of patients where you should definitely use it. But the type of equipment what they have used in the study, we don't know. I have not used that. We have not used it in India. The scenario for the quality and all those things takes a lower. It takes a lower level than the doing the procedures. But yeah, we can do it and should do it in patients who are more anxious, or in whom we think that the duration of procedure will be more, and who are anxious. But this is a therapy or the modality which can be easily used in patients on the OPD basis, or who are stable. I don't know how much it will be useful for patients in the ICUs, because they are on multiple medicines, multiple drugs and all. And in there, they have got their different zones of mentation and all those things. So, and they are some, most of the patients in the ICUs are on some of the other form of sedation, hemodynamic support and all. So I don't know how it will be helping in patients in critical care, but yes, the patients on OPD basis or stable patients, this can be tried out.
Yeah. So although this study didn't mention that there
Yeah.
was less use of sedatives, but then there are studies in 2022 that came up, and they did show that the patient required low doses, much less doses of, and there were control groups also, much less doses of sedatives. So what about you, Manoj sir? What would you like to use, and any particular group of patients you would like to use in ICU particularly?
I think first thing is a good counsel to the patient. The anxiety level is definitely there. But if you counsel the patients well and allay their anxiety, answer their questions, make them understandable procedure, that goes a long way. As a matter of fact, if you know that in Japan, people do e-bursts, all long procedures in conscious sedation, right? They're not using any kind of anesthesia because you're able to comfort those patients nicely. Now, my question to this is: somebody sedated is on VR. How is it going to work? So that is something in my mind. But people have done a study, and logistically, I mean, as Dr. Bindru said, patient who is very anxious, even if you sedate these patients, they don't sleep, and they're still quite alert. So those kinds of patients, it may help. I mean, this is non-invasive modality. If it can help, so I can use that, but I'm not sure with the sedation and everything. So
Yeah.
very few subset of patients. Now coming to ICU, possibly it may not be possible. We're using the HFNC, or you're using the NIV in those patients, so you can't put this device there. But in a routine bronchoscopy, in a bronchoscopy suite, a patient who is very anxious, who has been given a sedation, is still continue to be anxious. Possibly in those cases you can use that.
And
So
one
that
group,
could.
I think children maybe, because if we are doing in conscious sedation, I think this might help. And because it's quite, when I was reading and I've asked my colleague also, it's quite an immersive experience. It's like it's going back, like it's just dissociate you from the surroundings. So maybe children, and yes, definitely highly anxious patients.
The study is
So
definitely interesting. Yeah, so it's another thing which is there added in pulmonary medicine. So one can try that. Yeah.
We did had a fourth study in lung transplant patients, the role of interventional pulmonology, but Dr. Vijay Rahul, he caught up in a case, and we'll skip that, and we are running late also. I would like to thank Dr. Manoj, Dr. Bindru, and Dr. Vipul also for joining us and sharing such practical experiences of yours. Thank you. Thank you so much.